Dr. Nitish, thank you. Dr. Nitisha Khare. We have only 11 minutes. वही ना और दो
Very
बच्चे
good afternoon. Today I'll be presenting on comparison between conventional recession and hangback recession of extraocular muscles for squint surgeries. So strabismus, as you know, is malalignment of eyeballs in which both of the eyes are not directed simultaneously at the objective regard. It needs to be corrected because it leads to disturbances in binocular single vision and would lead to diplopia, confusion, eventually leading to suppression and even amblyopia. It may even cause cosmetic concerns to the patient. So, the common treatment modalities available include optical treatment in the form of refractive error correction or prisms, orthoptics, and surgery. Surgery is the mainstay of treatment, and surgical procedures are broadly divided into strengthening procedures and weakening procedures. My study today aims at comparing two types of weakening procedures, that is conventional recession and hangback recession. So, the basic principle behind both the surgeries are the same, that we are basically disinserting the muscle from its original site of insertion and we are reinserting it certain behind. So the difference, what this does is that it reduces the tension on both the muscles and it would reduce the arc of contact, thereby reducing the strength of the muscle. In conventional recession, we suture the muscle back a certain behind over the sclera, and in hangback recession, instead of suturing it, we let the muscle hang using the suture. So my study aims at comparing the two types of surgeries, and it was conducted at MNJ Western Regional Institute of Ophthalm, Civil Hospital, Ahmedabad, between August 2020 to July 2022, and we had a sample size of 60. We included 60 patients with concomitant strabismus. The patient's age group was more than 5 years, and only patients with primary surgery were included. The patient's consent was taken, and pre-op evaluation was done. And using prism bar cover test, the prism diopter's deviation was calculated, and accordingly, the extent of recession and resection was planned. On follow-up, the patients were evaluated, and the study and the results were evaluated. So amongst the 60 patients, 24 were females, 36 were males, and age ranged from 8 to 40 years, mean age being 23.78 years. 4 of my patients had esotropia and 56 had exotropia. 14 were unilateral deviations and 46 had alternate deviations. The mean pre-op deviation for near in conventional group was 54.5 plus minus 15 prism diopters, and for distance was 57 plus minus 15.01 prism diopters. In the hangback group, pre-op deviation mean for near was 47 plus minus 4.82 prism diopters, and for distance was 50.46 plus minus 5.419 prism diopters. The mean post-op deviation on day 90 was compared between the two groups, and no statistically significant difference was found. The successful outcome, we considered it to be less than 8 prism diopter post-op. It was compared, and again no significant difference was found. The post-op eye movements, on post-op day 1, 29 out of 30 patients in both the groups had some degree of restriction of movements, while by day 60, 25 out of the conventional recession group and 27 in the hangback recession had regained complete movements. Again, no significant difference was found. So what do we realize? We find that the post-op correction, movement restrictions, there was no any difference found. Complications also, no major complications were noted in either of the groups in my study. But as we study the literature, we find that as the hangback recession avoids the scleral pass, as a result of which the risk of scleral perforation, which is a major complication during the surgeries, is avoided. So especially in patients with thin scleras like high myopes, it is a very good surgery to be considered. And when we need longer recessions, in conventional recession, it is difficult to suture the muscle back over that behind the sclera. So in those cases also, hangback recession can be a very good alternative to consider.
Okay, this is well established that there is not much difference between these two techniques, but what is the novelty in your study?
So we compare the study, if any.
No, no, no. Take it. Then it's okay. Yeah, yeah.
For PG, one question. Scleral perfusion can be happen at the attachment at muscle site also.
Yes, so yes, so that can happen.
Yeah.
But so usually the yes, so that is a risk.
But for your
For sure.
PG.
So what just what is one disadvantage of doing your hangback?
So it has been found in some cases that in later stages pseudo-tendon formation may occur,
Yes.
which may lead to late
So that is the
yeah,
main
in some
reason. Even
cases.
if you have to do large recession, you do hemi hangback.
Yes,
So you
sir.
try to prevent this
So even
complication.
adjustable
Yeah.
suture hangback can
And it's a
be,
good thing.
but
Yeah.
that means
Yeah.
no, sir,
No,
not
it's
in the
a
long
very
run.
good thing.
Yeah.
One more disadvantage is you keeps titrating time and again.
And one thing more, there are the two schools of thought. Americans like more hangback and British like more conventional surgery. So there are two schools like this.
Okay, since we are running short of time, next